Hi, folks. I'm Pat McCarthy. I am the Executive Director of the Bloom Cardiovascular Institute at Northwestern Medicine, and I'm here to talk to you about matching the type of surgical ablation that you do to your atrial fib patients that show up the need a mitral valve or coronary or aortic valve, and they have AFib before surgery. It's a really common problem, and there's a lot of different approaches that people have to this issue. So recently, this was just published in JTCVS. Jim Cox and I put this approach together, and it's really to make it sort of a practical approach. You can read the guidelines about why it's important that we do this, but we want to really talk to the surgeon about, okay, how does this apply to the patient that you're about to see? And have to make a decision about if you're going to do an ablation or close the appendage, and if so, what type. So we really tried to make this very practical. First of all, it is now STS, we probably all know by now, a class 1 guideline to do concomitant ablation, both for mitral valve, which is a level of evidence A, but then also for aortic valve and coronary bypass. New this year for the guidelines as opposed to 2017 is it's also class 1 now to close the left atrial appendage, and that one is really very important. So why? What are the benefits? What did the guideline committee review that they said, boy, people really ought to be doing this? It's pretty straightforward. Well, if you treat patients with atrial fib and do a maze operation, they're going to be free of atrial fib. That's pretty straightforward. Look at the number of patients needed to treat. It's so small, and yet all the p-value is highly significant that 12 months later, those patients were more likely to be out of atrial fib. But the important thing is more than just, did we make the EKG look better? Did we give the patient a better result? And so there's a lot of data about AFib ablation and then also closure of the left atrial appendage. In the past, we'd have these large registry data looking at an improvement in stroke and mortality in patients when we close the left atrial appendage. But new since the guidelines were published in 2017 is this really critical paper from the New England Journal of Medicine. And this was the LAOS 3 trial. And this is a multi-country, huge study looking at thousands of patients. And if you close the left atrial appendage at the time of your concomitant surgery, there was a 33% relative reduction in stroke. Only takes you a couple of minutes to do this. And look at the benefits, which actually become more dramatic over time. The occlusion group stayed almost flat, but the no occlusion group kept accumulating more and more strokes over time. Class 1 guideline now, that's something you should really think about in every patient. Quick, easy, safe. But in addition, there's more and more information about AFib ablation. Adding a maze improves late survival. These are just the US studies. I could have had another slide that showed slides from other countries, but I think you get the point here. This is looking at Northwestern data, multi-center data, registry data from the STS. This is WashU data here. And so in every one of the curves, the lowest survival were patients that had AFib that was untreated. Those are always the red line. The lines above them are the group of patients that had AFib ablation. The top left one is showing a matched group of patients that never even had HOFib, and the survival was the same. So the story always becomes the same. Those small little studies that I showed you with 30 to 100 patients randomized were only being followed for like 1 year. We're never going to get this data from those type of randomized trials. They're just too small. But these large studies from registries, multi-center, long duration of follow-up, the study outcomes are always consistent. Here's another one. This is from the STS database. And so this one is looking at, well, do you need to do the surgical ablation or can you just close the left atrial appendage? And the answer is that The best is to do both. So there was actually a survival benefit if you just close the left atrial appendage. If you don't have one of those big strokes coming out of your left atrial appendage, then your survival will increase over time. But if you also do surgical ablation with it, then that's the best survival for that group of patients. And it's a huge study of 103,000 patients. Well, the surgeon is really sort of focused initially on what are the 30-day risks and what are the benefits. So the benefits, this is one of the studies from the STS, did show an early reduction in the relative risk of stroke and mortality for the patients that had an ablation, but surgeons just inherently have to manage risk. And so when we're operating on a patient, we have to consider, are we going to do anything and make this worse? And especially if an operation can be as complex as a Cox-Maze 4 by atrial ablation. So in the STS database, there was an increase in renal dysfunction, 1.12, and pacemaker implant, 1.33. So there was some increase in pacemakers and renal failure. So with all of that, the risks and the benefits, we wanted to think about what is the way to approach these patients. And they kind of fall into two groups. In one group are the group of patients with mitral surgery when the left atrium is open, kind of quick and easier to treat, and it is much more often treated in the real world. There's the other group where you don't open the left atrium or don't have to, such as a coronary bypass, an aortic valve replacement, an ascending aortic aneurysm operation. And so what we're going to do is we're going to sort of walk through this algorithm and think about how we approach these patients at Northwestern. So if they have mitral surgery and they're minimal risk, they're paroxysmal or long-standing persistent, everybody gets a clip, and then either a left atrial or a biatrial maze. If they're kind of increased risk or paroxysmal, or there's no right heart involvement, there's no tricuspid regurg, there's no right atrial enlargement, it's a very early asymptomatic mitral referral, a lot of those patients now get only a left atrial only maze. And we're going to talk about how do we do that and how do we keep it quick and simple, because renal dysfunction may be related to being on cardiopulmonary bypass a long time. And surgeons, we want to be efficient. We want to be quick about it. So cardioplegia is given. The left atrium is open to vent the left atrium. When that happens, the left atrial appendage deflates like a balloon. You don't need a measuring tool to put a clip on it or anything. It's just sort of becomes smaller. I always use a 35 millimeter clip to do this. I don't stop and measure. I don't really need to. And we always are able to do this. We started timing. How long does it take from the time you give the cardioplegia, you lift the heart to put the clip on, and then you cut the stitch and you remove the clamp, drop the heart back in, is less than 2 minutes, almost 100% of the time. So we use a clip. The meta-analysis systematic reviews show it's very effective, 98% effective. And also importantly for ablation, it electrically isolates the left atrial appendage. So the clip gets snug enough that it cuts off the blood supply, and therefore the left atrial appendage gradually becomes necrotic and electrically silent. That's one of the Cox-Maze 3 lines. So the next is the ablation. It's 3 ablations. Each one is 2 to 3 minutes. So it's 8 total minutes of ablation to do this. It doesn't require any epicardial dissection like you would with bipolar radiofrequency clamps. This is the old Cox-Maze 3 drawings from Cleveland Clinic, 2002. You have the box lesion here. You excise the left atrial appendage. That's how I used to do it. You have an incision of the mitral annulus, and then you have a coronary sinus freeze as well. So now we do it with cryoprobes. The first one I put across the dome of the left atrium. It sits on top of the left atrial appendage, which is going to become electrically silent. It's going to necrose, and usually the probe runs out at about P2. So that's lesion number 1. The second lesion is kind of a straight line. It goes here, and it goes down, and it has to overlap. This is the only lesion where you need to watch out. that it is going to overlap, which is right here where the two have to cross over. And you bend the probe a little bit and it goes onto the mitral valve tissue. And so you're getting the mitral isthmus lesion. You've created the box lesion right here, the really important box lesion, just like in the Cox-Maze 3. And you get the mitral isthmus line. And then here you're also getting the coronary sinus, which I have a cable tape on the IVC, and you can just put it in there. Direct visualization works really well. You need to always make sure you have good contact. Sometimes you have to push against the tissue or push the probe down against it. You need to make sure that this is in good shape. The third step is the right atrial lesion. And if you do left and right atrial, then you're going to have a biatrial lesion. I only do that in about 20% of patients, because my referral pattern these days, there's a lot of very early mitral patients that are asymptomatic with no right heart involvement. In this one, we're doing the right atrial to tricuspid isthmus lesion, which you're seeing right here. It actually goes across the tricuspid isthmus for about 1 centimeter. You can't get reentry around that tricuspid valve. And then you do the SVC and the IVC lesions as well. I stopped doing, this is the IVC freeze from the right atriotomy, and then this is going to be the SVC freeze. And you'll see we have a little additional freeze right here on the crista terminalis, which can be about 1 centimeter thick in some people. And so if it is thick and it didn't freeze, then just for another minute or two, you put a freeze on the epicardium. And I do the right side in general with the cross clamp off. The only thing we don't do is the right atrial appendage to the tricuspid annulus. You're not going to get a reentry around that annulus. You already froze around it. We've never mapped any failures to the right atrial appendage. These are the tips. If you haven't used cryoablation before, make sure there's no gaps. You want to overlap the lesions, but again, there's only one. You want to make sure the probe's in good contact across the entire line. So you have to bend the probe and reposition it as needed. This was just published in the Operative Techniques in Cardiac Surgery a few months ago, so you can look it up online. And I went into detail about how to bend the probe and position it. And then you push from inside or outside, relax or retract or whatever you need to make sure you have good contact. 3-minute freeze on thick tissue, that's the box lesion across the thicker part of the left atrium, and then that epicardial freeze as needed, as I showed on the crista terminalis. This was published also in JTCVS, as opposed to a lot of the literature. Because of the improved late survival, reduction in stroke, and to minimize the risk of complications by being quick and efficient, I do it in 100% of patients that have AFib before they undergo mitral valve surgery. So there's no 40% or 60% of, if patients have AFib and they need mitral surgery, 100% of them are going to be treated. It added just over 10.5 minutes of cross clamp time, 13 minutes of bypass time. There was no increase in renal dysfunction. Pacemakers were not increased. It was less than 1% for a mitral valve maze. And not only was the survival increased to what's expected for patients that never had atrial fib before surgery, but also to an age and sex match population from the CDC. First time we've done that analysis. So you're returning these patients to this expected survival for another 60-year-old or whatever their age is. Here's the 5-year freedom from stroke at over 98%. And then here are the 3-minute freezes. This is data as of a few months ago. At 1 year, 92% free from AFib, 2 year, 89%, 3 year, 82%. And that stacks up very well with the publications that you see in the literature with mitral and MACE. So there's a few decisions when you're thinking about what to do. Do you want to do bipolar radiofrequency or do you want to do cryo? Maybe you have to learn about doing cryo. To do the bipolar RF, you have to do the epicardial dissection. You have to come around the left side and pulmonary veins at a minimum. You have to dissect along the dome in the left atrium to get the clamp there. It takes therefore longer on bypass and cross clamp. I use very small incisions. It's hard to get the bipolar clamp through the small incisions to do that. And then also, you still have to do cryoablation, so you have to buy 2 devices instead of just 1. Then what do you do about how much ablation do you do? Do you do left atrial only, or do you do biatrial lesion sets? We really could use a prospective randomized trial on this because the data are just not that clear. What is clear, biatrial are associated with more pacemakers. Tends to be that biatrial are going in patients with long-standing persistent. They're a little different, hard to match for all that stuff. There is therefore also going to be more bypass time to add the right-sided lesions and more renal dysfunction. Is there a big difference in effectiveness? Not as much as you'd think. This is pulmonary vein isolation. This is looking at a meta-analysis here of biatrial, about 5% better, 4% in this than just left atrial alone. And this is from the CTS NET trial, where it was 66% with biatrial versus 61% for pulmonary vein isolation. So yes, the more extensive lesions that you do, you may get better freedom from atrial fib. But if you look closely at the data, it's usually about 5% difference in freedom from atrial fib at late follow-up. But at what price? More pacemakers, more time on bypass, et cetera. So for you individually as a surgeon, you need to think about your training, your experience, and then what are you comfortable with doing? Well, what do you do on this side? What about the CABG patient or AVR aneurysm group? This is, again, minimal risk, high risk, or reoperations. Those are even like more complex. So what if you do an AVR and a CABG in this group of patients and you're doing ablation with it? So there isn't that much published about the late results of aortic valve replacement. We, for a long time, did just pulmonary vein isolation with an AVR. 80%, 70% of the group had pulmonary vein isolation. We had 80% freedom from atrial fib off antiarrhythmic at last follow-up in the entire group. So pretty good. It was not a big study. It was not 5 and 10-year follow-up and all. And now we typically would open the left atrium and we would do the ablation that I just showed you. What about doing a pulmonary vein isolation or a left atrial lesion set? This is almost 300 patients with paroxysmal atrial fib, and they're undergoing CABG or AVR. Here's again the difference in freedom from atrial fib. Pulmonary vein isolation versus an extended left atrial lesion, 12 months, 5-6% difference again, which is almost always what the literature shows. It is a little bit better. It's not remarkably better to do that. There's a new clamp that is available called Encompass, and the clamp is a bipolar clamp with radio frequency. And this one, this is borrowed by, I borrowed this from Mark Gerdish. This is a video of putting the clamp in. You have to do this on bypass to do the ablation. You do a bit of a dissection, but it's not terrible, the oblique sinus and the transverse sinus. You use the red rubbers to help pass the clamp through on bypass. You then clamp this. You can clip the left atrial appendage afterwards. What about a reoperation? You're really limited there. Doing bipolar radio frequency, you'd have to do extensive epicardial dissection. If you have a patent left IMA to the LAD, it's not a good idea to go over the left side of pulmonary veins. You're not going to want to close the left atrial appendage from outside using the AtriClip. So when we have a reoperation, we open the left atrium and then we do the lesion set that I just showed you. The advantage is you're inside the endocardium for this ablation. You only need a minimal dissection of the epicardium under the IVC to get to the coronary sinus. And then to close the left atrial appendage, this double layer endocardial closure that Vinny Badawar has been showing with a robot, actually I think is a good option. You're not going to be able to manage that with a clip. So we're more than 35 years since the very first operation by Jim Cox for doing Afib ablation, and it's 20 years since the introduction of bipolar clamps by AtriCare. And so it's time, though, to really reimagine how we treat concomitant AF surgery. We're slowly growing, but it's too slow considering how good the evidence is now for reduction of stroke and improved survival. At a very minimum, like if you think of it as like being a baseball game, first base is just close the left atrial appendage. Any surgeon should be able to put a clip on the left atrial appendage. It takes less than 2 minutes. You're going to reduce the risk for stroke. Add ablation whenever possible. It is a benefit on top of doing the left atrial appendage. There are ways to do it that are actually pretty good. People will tell you that it has to be a Cox-Maze 4 or don't do anything. And unfortunately, too many people believe them and they do nothing. That's not really true. I showed you the data comparing biatrial versus left atrial and pulmonary vein isolation versus biatrial, and pulmonary vein isolation at a minimum works pretty well. I don't really suggest that you do pulmonary vein isolation. I'm just saying that if you need to start somewhere, that's somewhere that you can do that. So use a technology and a lesion set that you're comfortable with, but take a course. There's a lot of courses out about learning something new. And the technique that I just showed you with cryoablation is really pretty quick and easy. There's not a lot of pitfalls with that one. So thanks very much, and I hope this was worth your while, and I hope that you learned something new and that you're going to go out and close those appendages and that you're going to do more ablation. Thanks, everyone.